Oh, I should change my name. It says I'm Kathleen.
You could do worse.
I could. I could do worse. Here, let me put my real name. That'd be helpful. There. Should I get started, Derek?
Yes, anytime you'd like. I'm
Okay.
sure we'll have some people rolling in, but
Oh,
go ahead.
sure. Okay. So, hi, I'm Matt Groshong. I'm chair of the RPEC Healthcare Workgroup, and we want to welcome you to this educational webinar on Medicare open enrollment. We will cover Medicare Advantage, Original Medicare, which is also known as Traditional Medicare, and Part D drug plans for those who purchase your health insurance on the commercial market. And that means you either buy it yourself directly from the insurance company or through a broker or insurance agent. The webinar is brought to you by RPEC's Healthcare Workgroup, which works hard to help RPEC members navigate our complex and often confusing healthcare insurance system. It is also brought to you by our dear partners at SHIBA, the statewide health insurance benefits advisors, impartial advisors out of the Office of the State Insurance Commissioner. Before we get to introductions, RPEC Associate Director Derek Van Spoor will go over a few housekeeping items.
Thank you, Matt. Good morning, everyone. Thank you for attending today. We do ask that you remain muted during the presentation so we don't have background noise. We will take questions, and if you have any questions along the way, please drop them in the chat. The chat button should be down at the bottom of your screen, and we'll take a pause after each section, and Tim and Matt will field questions. And I think that's about it.
Great. Thanks, Derek. And thanks to the Healthcare Workgroup and Derek, the RPEC website has an entire page dedicated to Medicare and open enrollment, filled with resources compiled by the work group, including past webinars, podcast episodes, frequently asked questions, a glossary, and more. It's full of info. Now for introductions. I'm joined by Aruna Bhuta, a member of Chapter 13 in Spokane, who since retirement has served on aging advisory councils, the Washington State Council on Aging, the Spokane Regional Dementia Friendly Community, the RPEC Legislative Committee, and the Healthcare Work Group. She is also a highly trained SHIBA volunteer. And lastly, I'd like to introduce Tim Smolen, who is the program manager, the big cheese of SHIBA, an incredible, impartial group. Tim is a state employee. It's a totally impartial organization, and that is hard to get, impartial information. So Tim is a walking encyclopedia of all things Medicare. So I'm going to hand it off to Tim. And once again, Tim, thank you for helping us out here at RPEC.
No, it's my pleasure, Matt. As you know, I'm a big fan of RPEC, and I think you guys do really important work. So appreciating that you all in retirement are continuing to be advocates and help support other people in the community through all the issues related to retirement and healthcare. If you're not already aware, Matt and I have done several programs together with support from Derek and the folks at RPEC. I know Jacob is here this morning. So there's some great kind of webinar resources that we've recorded over the past couple of years. And I had the pleasure of attending your convention last year in Wenatchee. So this partnership means a great deal to me. And I am looking forward to today's program. We made this program specifically to talk about open enrollment, but I'm going to just start by providing a little bit of context about the Medicare program, just so that we can have a kind of frame of reference for open enrollment. And I have way more slides than we can cover in the time that we have today. I need to hop off at 11, so apologies. I'll try not to be abrupt. And so, as Matt said, we'll talk for a little bit, and then we'll have some questions and answers. But feel free to use the chat feature along the way. Derek and Jake will be checking in the background to make sure that we don't go too far afield. I know it's hard to have a question in your mind and hold on to it, and not being able to ask. So we're trying to balance that. Let me see if I can share my presentation with you. And then I'll kind of talk from this, but again, mostly it's meant to be, conversational. It's a serious topic, obviously. I take it very seriously. I know you take it very seriously, but I hope that we can have some good dialogue as well. Matt, are you able to see the screen?
I can, yes, thank you.
Okay, so this is my contact information. I'm better at email than I am on the phone, but it's a sincere offer that you can reach out. If you have a question or if there's something that I can help you with, please feel free to reach out to me. And we'll make the slides available, and this program will also be recorded. So in case you're not familiar with the SHIBA program, we have 45 years last year. It's a volunteer-based program. So myself and the professional staff train volunteers like Aruna and Prakash, and we're really trying to make volunteers available in person, on the phone, or virtually to help you with questions. A lot of our work, of course, is about getting started in Medicare. So we do a lot of work about eligibility and enrollment. That transition into retirement can be difficult. Also, transition from Apple Health for people that have Medicaid, or from one of the qualified health plans if you have the health benefits exchange for Obamacare. Obviously, open enrollment is peak season for us. We do about half of all of our work during the Medicare open enrollment period. And then we have lots of, general conversations for people who are already in Medicare throughout the year, navigating their benefits. And we are the designated Senior Medicare Patrol Project. So we help people prevent, detect, and report fraud in Medicare as well. So at a high level today, I want to talk about Medicare, the program. I'm going to start with kind of a policy perspective, and then talk about some practical issues related to Medicare. Obviously, we'll talk about Medicare open enrollment. A big issue every year is people switching from Medicare Advantage plans to original Medicare and getting a Medicare supplement or a Medigap plan, and who does or who does not have guaranteed issue rights. So in other words, they cannot be turned down for a policy. And then this year, lots of conversations about this pilot project called WISER that CMS is initiating starting in January. So if there's questions about that, we don't have to necessarily talk about it, but if there's questions, I'm happy to take those. And then I hope, as I say, ample time for questions and answers along the way, or when we get to the end. And I'm not going to obviously go through all the slides word for word. So it's just meant to be a visual aid and then a resource for after the program. So Medicare as policy, I think sometimes we can get really into the details about navigating Medicare, the complexities that each individual experiences. And as important as that is, I feel like, especially now with the Trump administration really taking a very, very assertive role in healthcare policy. Mostly Medicaid has been in the news, but I'm sure that in the couple of years ahead, Medicare is going to be it is going to get as much public attention, more attention than it has in a number of years. So I just feel like it's worth just to take a moment and talk about Medicare as policy. So from my perspective, Medicare really is, and on purpose, is universal health insurance for older people and some people with disabilities. I did a program earlier this week with our friends at the Snoqualmie tribe, and there was a young woman in the audience, Mackenzie. Mackenzie's 13. And I asked permission. I said, Mackenzie, I want to talk about you. And her grandma was there, Jerry. And I said, I want to talk about you in front of the room, if it's okay with you, because a fundamental kind of misconception about the Medicare program is like Medicare's for old people. Now, 65, we could debate whether 65 is old or not, but about 15% of people in Medicare are younger disabled people. There is a bunch of 13-year-olds that are enrolled in Medicare. Recently, I was traveling and I was at the airport and talking to a woman who her niece had just been born with a congenital birth defect. So she needed kidney dialysis immediately and was going to be a candidate for a kidney transplant. So she's immediately going to get enrolled in Medicare because she has end-stage renal disease. And so literally infants or young people, and a lot of these people have what you might hear referred to as invisible disabilities. So I'm thinking about people who have severe persistent mental illness and it's debilitating. They qualify for disability and enroll into the Medicare program. So I'm just wanting us to appreciate that it's a very, very diverse program. Even among the people who are 65 years and older, the healthcare needs of 65-year-olds are not the ones of 75, 85, 95-year-old people. And there's lots of other different ways of thinking about the diversity in the program, but it's a very diverse program. So it becomes a very challenging program in terms of making policy and making policy changes. I think Medicare also doesn't get enough credit for the profound effect it has on managing healthcare spending in this country and managing financing for healthcare. We wouldn't have any of the technologies that we have now if it wasn't for Medicare. The fact that we have this kind of group purchasing power is what makes Medicare work, and it's what makes really the entire system of medical care in this country work. Medicare really sets the rates, not just for the Medicare program, but for the industry at large. And Medicare has a very sophisticated quality assurance program. It really does raise the level of quality of care across the whole country, just because it's such an influential payer. And a thing that we hardly ever talk about that's very important is that Medicare pays most of the cost of graduate medical education programs. So all of the residents and interns in all of the teaching hospitals around the country, that's all paid by Medicare. Mm-hmm. And so I just think we can and we certainly do kind of assail the Medicare program for all the ways it disappoints us. But I think it's also fair to say that it's a significant driver of policy for a lot of people in the country. Okay, practically speaking then, some things to know about Medicare. Eligibility and enrollment for Medicare is actually managed through the Social Security Administration. So way back in 1965, when President Johnson signed the Medicare legislation, the Medicaid legislation, and the Older Americans Act legislation as part of his Great Society programs. Part of how he got it done, and credit to Wilbur Mills and clever people in the Congress, and even more so their staffers, of course, but it is literally, Medicare is an amendment to the Social Security Act 1933. So the eligibility and enrollment was really delegated to the Social Security Administration because it was already in place. It was a way to stand up a very complex program by using an existing model. And a lot of that is about taxation. So as a working person, I pay a tax into the Medicare Trust Fund to pay for Medicare Part A, which looks very, very much like how I finance my future Social Security retirement benefit. I have a payroll deduction when I'm working so that when I retire, I have some basic level of income. So that's why Social Security manages eligibility and enrollment. When I say someone qualifies for Medicare by virtue of disability, I mean the definition that Social Security uses, not what labor and industries might use, or the state of Washington might use, or a private employer might use, but the one Social Security uses. The rest of the program then, the Medicare program, is managed by the Centers for Medicare and Medicaid Services, or CMS. So they're responsible for taking the laws that are passed by the Congress, the funding that's appropriated by the Congress, and turning that into policy and administration. you're going to hear me refer to Medicare as an entitlement program. So it's not subject to annual authorizations. So in that way, it is similar to Social Security. It's just the responsibility of the government to find the money to fund the program, but it's not kind of beholden to these annual appropriations proposals that, like other things, have to work their way through the Congress. So let me just take a moment to acknowledge that for all intents and purposes, Medicare is not affected by the current partial shutdown of the federal government. Most of the work of the Medicare program is actually done by contractors, and that's been true since the beginning of the program 60 years ago. So you can still call 1-800-Medicare. The Medicare.gov website still works. And so for all intents and purposes, I can't reach some of my colleagues that I want to correspond with, but a beneficiary's experience of Medicare should not be interrupted by the partial shutdown. Medicare also enables what I'm going to refer to in this program as other insurance in addition to Medicare. So for those of you who are retirees from the state or school districts and you have your insurance through the HCA-PEBB system, we wouldn't really be able to have that kind of insurance for retirees were it not for Medicare, because Medicare pays first. Medicare pays most of the cost of retiree health insurance. And so it makes it more possible for public and private employers to offer benefits because Medicare is paying the bulk of the costs of your health care. And as I said earlier, it really shapes how the rest of the industry works. It's a very common practice for private insurance companies to design their fee schedules around the Medicare fee schedule and to adopt Medicare technology. So it very much shapes how private insurance is administered because it's just such a big, complex program. And then finally, again, I think a thing that's a bit underappreciated about Medicare is it really does promote access because it is that sort of universal healthcare system, and because of the ways that it was initially conceived back in 1965, it really has created, of course, not universal access, but it's gone a long way to improving access. And personally, I always like to mention that one of the really wonderful things about the program was from the beginning, it was a stipulation that in order for hospitals to receive funding from Medicare, they had to comply with the Civil Rights Act 1964. So practically overnight, we integrated hospitals just because of the Medicare program. So I just think, obviously, I'm a fan of the Medicare program, right? That's probably already clear. So, okay, insurance in general. A lot of people don't understand how insurance works, but insurance is literally a contract. And I think if we start from that perspective, it makes all the other conversations kind of go better. So think about there's a service, and the question is this part of my insurance contract? Yes or no? Is the company going to pay, or am I going to pay, or are we sharing the cost? So in practical terms, then you're going to hear me talk about like an evidence of coverage. So if it's not clear, go find that, and then it'll be clear about whether you have coverage or not, and what kind of coverage, the limitations, the exclusions. It's literally a contract. The other significant thing for people to know about Medicare, and again, this goes back to the inception of the program, is that it's a major medical program, right? So politically, in order to pass Medicare, because it was very, very contentious, it was not universally accepted as a good idea. It was modeled after the insurance that was contemporary back in 1965. So there was not a lot of private insurance, but predominantly we had Blue Cross plans, which paid for hospital care, and Blue Shield plans, which paid for medical care. And that's really what's behind you having Medicare Part A for hospital and Medicare Part B for medical, and why we have this, pays 80% of a doctor's bill, because that's how insurance was organized. And it doesn't pay for prescription drugs because insurance didn't pay for prescription drugs. Prescription drugs didn't matter. People didn't use them the same way, and they weren't nearly as expensive. So it just didn't seem like a thing that you needed to buy insurance. You could afford to pay for it. This is 60 years ago, right? So now that's no longer true. And it's a fair critique of the program. Why does it not include more benefits or pay more? But again, it's a political solution, right? So it's always going to be contentious in that way. So for virtually everybody in Medicare, you're going to need other insurance in addition to Medicare. You want to take care of services that are covered but not paid 100%. You want to take care of services that are not covered at all. And you want to make sure you understand, again, limitations and exclusions. But almost no one has just Medicare. So the most common solutions then are going to be, as Matt said, original Medicare. You have a Medicare supplement plan plus a Medicare Part D prescription drug plan, or Medicare Advantage. You have a Medicare Advantage plan that includes prescription drug coverage, or you have insurance from the place you used to work, from the company or the union. I'm going to refer to that as an employer group health plan, or you have Medicare and Medicaid. So you're what we would call a dual eligible beneficiary. And I'm talking about full benefit Medicaid. So it looks a lot like retiree health insurance in the way that Medicare pays first, Medicaid pays second. So those are the four most common solutions for Medicare plus something else. So virtually everyone in Medicare aligns to one of those four approaches. And I'm going to do a couple more slides, and then I'm going to stop for questions, Matt and Aruna. So when I talk about Medicare, I'm talking about the left-hand side of this page. I'm talking about your entitlement to Medicare Part A, Medicare Part B. On the right-hand side of the page, then I'm going to say Medicare health plans. So this is Medicare Advantage plans, also called Medicare Part C or Medicare Part D prescription drug plans. So again, your Medicare entitlement, Part A is your hospital or inpatient benefit. For most people, there's no monthly premium because you paid a payroll tax when you were working that was invested into the Part A trust fund. The Part B is medical or outpatient services. The standard premium for 2025 is $185. So by law, the way that this works is we make a forecast of the total cost of Medicare Part B for the year ahead. We assign 25% to beneficiaries, and the government pays the other 75%. So we're a couple of weeks away from having a 2026 number for your Medicare Part B premium, and it's going to be on the high side of $200. There are some people who pay a higher premium for Medicare Part B. You'll hear this referred to as IRMA, or the income-related monthly adjustment amount. That's a relatively new change in the Medicare program, and it's meant to just help relieve some of the cost of the Medicare program to the federal government. And if you don't already have one, this is what your standard red, white, and blue Medicare card looks like. Okay, Matt, Aruna, let's stop there and see if we've got some questions already or commentary.
I don't have any questions in chat yet. Anybody have any questions, want to raise their hand? Elliot.
I've often wondered why Medicare doesn't cover eye exams. Why isn't that considered medical?
It's a great question. So there's a distinction, Elliot, between, I would say, things that are a medical procedure. So I wear glasses. I have them in my pocket. So when I go to the doctor just to say, is my prescription still good? That's not a medical procedure as far as Medicare is concerned. If I had a disease of my eye, like cataract or glaucoma, treating that would be covered by Medicare. And again, you know, the kind of fundamental reason is just because most people can afford to pay for the cost of an annual eye exam, or at least it used to be more affordable.
Okay, because that's what kind of, because I was told I need, it's not about me, but I'm just saying, let's say you're sitting there and the doctor says you need a cataract exam.
Yep.
To me, a cataract surgery, I thought, why isn't that covered? Because without that, I couldn't get the cataract surgery. It's not logical.
Right. So your surgery would absolutely be covered, and procedures to diagnose something would be covered. So it's not a perfect distinction, but think optometrist compared to ophthalmologist.
Well, my procedure was, and the diagnosis was done by an ophthalmologist.
And so that should have been covered by Medicare.
He said it was okay. Well, anyway, thank you.
You're welcome.
All right.
Chris, you have a question?
Christine.
You're on mute there. I heard someone refer to you as Chris. Is that how you prefer?
Yes, thank you. Thank you for the information about younger people being on both Medicare and Medicaid. I had just learned about that myself with a friend, and she's in her 40s, and I wondered how could that be? So it depends on different medical diagnosis. Is that correct?
It is.
Yeah. Thank you.
You're welcome.
Yeah, Tim, are you going to get to Medicare Advantage versus original Medicare and Medigap?
I am.
Because Elliot's question ties in perfectly with Medicare Advantage versus original Medicare regarding glasses and hearing and gym membership and things like that. And that's a super important distinction.
It absolutely is. And I'm going to get there. But if I don't, Matt, then please take us there.
Okay.
All right, let's talk. I'm just giving you like a very kind of just a primer today. So, but please ask questions if I don't go far enough or deep enough. So how about eligibility for Medicare? Again, eligibility is a function of the Social Security Administration. As with other things, much easier to do on their website. So you can sign up for Medicare, get started in Medicare at Social Security. In general, eligibility means that you are either a citizen or a legal permanent resident and 65, disabled, end-stage renal disease, or Lou Gehrig's disease. So the most common is older people over who are citizens. But again, lots of diversity in the program. So Social Security does determine eligibility. Social Security decides whether you have a premium for Part A or not. Some people don't have enough qualifying work orders. They didn't pay enough into the trust fund to get Part A for free, so they may have a premium. Most people don't. And they decide what your premium is for Medicare Part B, whether you get the standard premium or that surcharge for high income earners. So again, the standard premium for 2025, $185. People with very low income can qualify for the state to pay their premium. We refer to these as the Medicare Savings Program. There are lots of people who qualify for this support that are not signed up. And so we really want to raise that to their awareness. And then for high income earners, there is this thing called the income related monthly adjustment amount, which is a surcharge that people pay, so they would have a higher premium than the standard Part B premium. So most people don't know very much about Medicare, but the one thing that's kind of top of mind for them is don't be late. If I'm late, I'm going to have a penalty. So they're concerned about being late. The related part of that is lots of people have the idea that it could be okay to wait to sign up, but they're not exactly sure who can wait to sign up and how you do that and how to get started again later. So a couple of points I'll just make here. It is very important to be on time. There are penalties for being late. Being on time means different things to different people. So it's fundamentally different for, again, over 65 compared to under 65. It's different for people who have coverage from their job compared to people who don't. It's different for people that get free Part A or free Part B from people that don't. The fundamental challenge, though, for a lot of people is that recently, in the past decade or so, we have this divergence between, it used to be you got your full Social Security benefit at age 65 and you started Medicare at age 65. And that's no longer the case. For people like me, I'm going to have to work till past 66 to get my full Social Security benefit. So the age of Medicare and the age of a full benefit are no longer the same. And so we have a lot of people who will arrive at age 65, but they're not drawing a Social Security pension, so they're not going to be automatically enrolled. Or we have people who are deferring signing up for their Social Security benefit because they want to wait until they're age 70 and they optimize or maximize their benefit. And so they want to defer Social Security. They're also not going to be automatically enrolled. And then just a caveat here for a lot of younger people now are enrolling through their job in what we call a high deductible health plan, and they're making contributions to a health savings account. So special rules about that the IRS makes. And so when we're talking about that transition from employment into retirement or job-related healthcare into Medicare, we just want to make sure we understand kind of these dimensions for people. And I have a chart here that kind of describes if you were imagining getting a consultation from a SHIBA volunteer like Aruna, then we're going to ask you about yourself so that we can have a good conversation and make sure and do an adequate job of describing your rights and options for you.
Tim,
So, yes, sir.
this is a good example of why you get a hold of a SHIBA volunteer. Tim is just starting to get into specific kinds of Medicare plans. And already my brain, and I know more than the average bear about this, I'm not an expert, but I'm already starting to spin a little. And so mistakes happen all the time with Medicare beneficiaries. We make mistakes all the time, and people call Tim and say in January and go, well, wait a minute, my doctor isn't covered anymore, and the drug I have isn't covered anymore, and what do I do? And Tim goes, well, you wait until next year, and then it'll get taken care of, right, Tim?
Yes, as kindly as possible.
Yeah, you say it as kindly as possible. So these details matter, but it's not like we listening to this. I want to reiterate, we normal people, not Tim and Aruna, but we aren't expected to know all this. What we're expected to know is, gee, if we aren't absolutely sure of something, we need to ask a SHIBA volunteer. You might have a broker who is reliable, who can give you a straight answer. You might have an insurance agent. You might have a friend, but people give wrong information too. So you really have to, like Tim says, it's effortful to learn this stuff, but the payoff is huge. You might save big money on premiums. You might save big money on your prescription drugs if you make an effort to engage and do some research and find out which plan is best for you. Sorry, I took so long, but
no, that's a great commercial, because it even if you feel pretty secure, just to say, hey, this is what I'm thinking. Have I missed anything? It is probably worth just a quick consultation. Hey, Elliot.
Yes, thank you. The thing on brokers, the law has changed on that. It used to be that if you called a broker, this is a broker to help you pick the right drug plan, okay? And there may be for other reasons too, but the brokers used to get paid by I don't know how, but I didn't have to pay. This year, when I looked for a broker, the broker said, well, you've got to pay me. Now it's the person who needs the service who has to pay.
This is a big deal issue right now. So maybe I'll answer the question now, and then time permitting, we can come back to it. So two things, Elliot. So brokers are not allowed to charge you for a consultation about Medicare Part D. The rules don't allow that. And the second thing is, it's true that we're having a lot of upset right now because a lot of the Medicare health plans, so I mean Medicare Advantage plans and Medicare Part D plans, have reduced or eliminated the commissions or changed the incentives for the brokers. So there's a lot of very upset agents and brokers right now with the insurance companies that they represent because of the change in the commission structure and the way it was communicated to them. So that's an issue that I deal with a couple times a week right now.
Wow.
But Matt's advice still holds. They are still out there, and there's always a little bit of tension between the brokers and the SHIBA volunteers of the kind of like, we're taking their business away, which is absurd. But yes, the SHIBA volunteers can do a consultation for any of you all about a Medicare Part D plan, including using the technology at the Medicare website or enrolling you if you need that kind of help. So
I wanted to bring up, many times people feel like I don't take any medication, or mine is generic and I don't need to enroll in Part D. But once again, there are Part D plans which are zero premium. And you can start with it, because if you don't enroll in a timely manner in Part D plan, also if you are on original Medicare, then you will be charged penalty, just like it is for late enrollment for Part B enrollment too. Thank you.
No, thanks, Aruna. That's great. Chris, let me answer your question in just 1 second. So I have a picture to show you that talks about what being on time looks like. So if you're not going to continue working for a large group employer, then being on time for you means, in my example, I'm going to turn 65 on April 6th. So my Medicare benefits will start April 1st. The best case is to sign up the 3 months ahead of your birthday to be on time. If you're going to continue to work past age 65 and be covered by a large group employer plan, then on time for you looks like start Medicare on the first day of the month after you stop working. So if I know that I'm going to quit working at the end of January, I want to sign up before the end of the year so my Medicare benefits start February 1st. So in general, the way that I want you to think about it is ahead of your birthday or before your last day of work. That's what being on time looks like. So as Aruna said, if you miss that, then we're going to have an issue with late enrollment penalty. So please don't do that. Chris, what's the question, please? You're on mute there, my friend.
Many older people are on limited income, and they can't understand why they have to pay to them a costly insurance to get two inexpensive medications. And a friend of mine was complaining. I says, remember, insurance has been around in the human history for a long time. Ben Franklin sold insurance. And I says, you're paying for the uncertain future of your health care.
Yes.
And you're also paying for all the people that work in the prescription industry. For instance, for our state agency, who dispenses medications and does research, and also for the research pharmacy. Yeah, thank you.
Yeah, that's 100% exactly right. I want to talk a little bit about group health insurance plans. So again, I'm talking about you have Medicare insurance, and then you get another different insurance to go with it. For a lot of people, and for a lot of people in RPEC, this is insurance that you get through PEBB, through the HCA PEBB program. For a lot of other people in RPEC or who come out of government service, so I'm talking about like public service districts, hospital districts, cities, counties, you're going to get insurance through a commercial market plan. And that can be, again, a Medicare Advantage plan or a Medicare supplement plan. it's just important that group plans are different. And so when we're trying to help you to say, do you get your insurance from a group, or are you buying it as an individual in the commercial market? Because if you just tell me, if it was Kathleen, Matt's wife, and she said, I have United Healthcare, well, I need to know more about your insurance. Did you get United Healthcare like from PEBB, or did you get United Healthcare from the commercial market? And if you got it in the commercial market, was a United Healthcare Medicare Advantage plan, or was it a United Healthcare Medicare Supplement plan? Because they sell all of these kinds of plans, right? So you can't just say, I have a Chevrolet, because I don't know if you have a car or a truck, a gas-powered vehicle, a diesel, an electric, right? We just have to have that kind of conversation. And so as Matt said, we just want to be careful to not generalize too much. So if somebody says, what's the best healthcare? You should get United Healthcare. Well, I think we just have to be a little bit more thoughtful about how we support each other like that, right? So a typical question for people about an employer group plan, I have this conversation every year with my mother, is, gosh, it's pretty expensive. And it's true, it is pretty expensive. And the reason is because it's better coverage than what's available in the commercial market. So I'm not saying you should always do it, or it's the best choice, or it's the best value, or it's the best investment. But you just have to understand that it is different, right? It's a little bit apples and pineapples. So it's more expensive because it's better insurance. Now, for some people, that doesn't mean that it's the right choice. You can get a zero premium Medicare Advantage plan compared to, Matt, I can't remember, the United Healthcare plan or the Kaiser plan in PEBB is going to be $150 or $170. So it may not be the best value for you, but you just have to appreciate it's not the same plan. You can't just say they're the same. It's not worth it. You can say it's not worth it, but make sure you understand the details about the plan. If you're thinking about leaving the group, be aware that it might affect other benefits that you have. It might affect your dependents. And if you exit, it's unlikely you can go back again later. So in general, making a change inside the group is pretty permissive. Go from UMP to UHC to Primera to Kaiser inside your group. But if you exit the group, you're not coming back again. So that's just a very important thing for people to understand. So don't misunderstand that. I guess that's the point. So in general, how is group insurance better? It provides additional benefits that are not covered by Medicare. You're generally going to have a better provider network, and you're generally going to pay less when you go to the doctor or the hospital or the specialist or for your drugs. And so those are the kinds of details that I'm wanting us to pay attention to when we compare group plan compared to commercial market plan. It costs more because it's better coverage. So whether you get the benefits from PEBB, like I say, or Boeing, or the federal government, you are still paying your Medicare Part B premium. These plans, again, Medicare first, your plan second, so they require that you enroll in Medicare Part A, Medicare Part B, and pay the Medicare Part B premium. For most people, the Part B premium is a deduction from their Social Security check. For most people, their group health plan insurance is taken out of their pension check. So in the case of PEBB retirees, that would be Department of Retirement Services. And then, of course, you're going to pay your copays, deductibles, et cetera, and pay for anything that's not covered by the plan. So this is the conversation that Matt and I like to have about, am I better served by original Medicare, or am I better served by a Medicare Advantage plan? Some groups offer both, some offer only one or the other. So inside your group, you might have these choices. In the commercial market, you for sure have these choices. So I'm going to say on the left-hand side of the page, original Medicare, that's your Medicare Part A, Part B, that's your entitlement. Because it is like a major medical policy, you're going to want a Medicare supplement plan that's going to pay the 20% of the doctor's bill that Medicare doesn't pay. And you need a Part D plan because, as Aruna said, Medicare doesn't pay for prescription drugs. And if you don't sign up on time, you're going to be penalized. So if you're going this direction, your red, white, and blue card, a card for a Medicare supplement or Medigap plan, and a card for your Part D plan. What people like about this side of this kind of the ledger generally is that it's the most permissive, right? Essentially, any doctor that contracts with Medicare will take your Medicare insurance and your Medicare supplement plan insurance. So you have a lot of freedom of choice. The significant downside is a Medicare supplement plan in the commercial market is going to cost you about $250 a month. So you're going to spend, several $1,000s a year, whether you use your insurance or not. Now, some people like Chris are going to say, that's why it's there in case of an emergency. And other people are going to be very resentful. Why am I paying all this money every month and not getting anything back again? Okay, that's fair. On the other side of the ledger, then we're talking about Medicare Advantage plans. So this is like a package then. You retain all of your rights and options for Medicare Part A, Medicare Part B. You still have your red, white, and blue Medicare card. And now you have a contract with a private insurance company. It's going to take care of the part of the bill that Medicare doesn't take care of. It's going to take care of prescription drugs. And as Matt said, it's going to offer additional benefits. So you hear vision, dental, hearing, food card, transportation, gym membership, right? And those things, plus the low or zero premium, is the big attraction for those plans. The downside is they are managed care plans run mostly by private insurance companies that are mostly for-profit companies. And so what you end up with is concerns and complaints and friction around things like provider network, prior authorizations, referrals to see a specialist, delays in getting treatment. So it's not that one is better or worse or right or wrong. It's just that they are fundamentally different approaches to how you access your Medicare benefits. And Matt, let me have you jump in here.
Yeah, thanks. I have a little spiel here. I'll keep it short. You could look at the difference between original Medicare with a Medigap plan to cover that 20% and a Part D drug plan as a package. Then you can look at Medicare Advantage as a package. It's got everything and all the different benefits, additional benefits like hearing and gym and some dental and all that stuff. Okay, so there are two different packages. Basically, with original Medicare, you'll probably pay a lot more, like Tim said, $250 a month. Okay, so you're paying $250 a month and you're going along and you get above the deductible. And the deductible, what, Tim, $257 or something like that? So if you have original Medicare and you have $257 in a year of medical expenses, the huge majority of the time, you aren't going to pay anything else for medical. That's it. So you're paying $3,000 a year for your Medigap plan, but for medical, not drugs, but for medical, you've paid it. It's covered. And you go to any doctor who accepts Medicare in the United States, you're done. So for somebody, and I'm that somebody, I'd rather pay more in advance and know that I'm not going to have any surprises or relatively few. Then on the other side, there's Medicare Advantage. And the Medigap folks are up here paying that $250 a month. And another person is down here paying $0 a month. $0 a month is pretty attractive, right? But just like any other insurance, you get what you pay for. If you get really sick or you have something that's taking long-term care or you need care for a long time, chronic condition, you're going along and you get sick and boom, there's no $257 deductible. Many of them have $6,000 to $9,000 deductibles before they pay 100% of the care. So if you aren't sick and everything's great, you're paying $0 and you're going, oh my gosh, I am saving a huge amount of money, and then you age, you get older, like we all do when something happens, then you could be paying 6,000 to 9,000 a year. That's more than 3,000 a year for the Medicare, for the Medigap folks.
Mm-hmm.
You're, you know, so you might save hundreds of thousands of dollars staying on original Medicare if you have a number of medical conditions. And if you go through life having very, very few medical conditions, you could save hundreds of thousands of dollars. So bottom line, what is your view of risk? How do you feel about risk? If, like Tim says, if you have a car insurance policy, do you have a $200 deductible for comprehensive, or do you have a $3,000 deductible for comprehensive?
Mm-hmm.
Thank you.
Yeah. Thanks, Matt. Hey, Aruna.
The point I wanted to bring it quite often, the dental and vision and all those benefits are very attractive to people, which are not part of original Medicare, but they are part of Medicare Advantage plans. But one needs to find out specifically what the plan truly covers, because quite often it may be just yearly, dental cleaning and preventive care, or maybe twice a year, but may not cover if you need, periodontic work, or if you need implant or anything of that sort. All those needs are different. So you have to, based on your healthcare needs, you have to make decision as to whether your doctor is in the network, because the networks are quite, very limited. And also to, if you are in the rural areas, then it is more difficult, to get the care from the specialists that you want. So based on the health conditions, you want to make the decisions. And this year they have also, included something like they would pay back the part of the premiums or something of that sort. It looks very attractive, but you want to see how much are your copays and how much are your deductibles for your healthcare or for the drug coverage, because most of the Medicare Advantage plans also include the prescription drug plan. And, there are some exceptions, but at least most of them do. And their deductibles are higher, or copays are higher. So you may feel like I'm getting some money back, but truly look at the big picture and make the decision, because this is a private industry which is, trying to have more and more people move into the Medicare Advantage group. Thank you.
And
Thank
Tim,
yes, sir.
One other quick thing.
Yeah.
I want to reiterate what you said about prior authorizations. A lot of people don't understand what that is. Traditional Medicare, there are some prior authorizations. There always have been. There are a few more now with the Wiser thing. But with Medicare Advantage, there are lots. So what does prior authorization mean? It means the doctor says, you need to have this CAT scan. And so they send it off to the insurance company, and you have a Medicare Advantage plan. And the Medicare Advantage plan goes, no. Okay. If you don't want to deal with that kind of thing, you stay with original Medicare. If you're willing again to take the risk that your doctor is going to say you need this treatment, and the insurance company is going to say no, or they're going to delay it, or they're going to limit the amount of treatment you can get, great. So there you go. Another difference between the two.
Yeah, and I'll say, we now are about 50-50 in Washington State, folks that have a Medicare Advantage plan compared to folks that have original Medicare. It's trending towards Medicare Advantage plans. People in both systems are equally happy, right? When we survey people, 75% of people over here, very happy. 75% of people over here, very happy. So it's not as if one is preferred compared to another. It's very individual.
It is.
Tim,
I'm sorry, go ahead.
Tim, I'm sorry. This is Charlie. There's a
Hey, Charlie.
when you were explaining the original and Medicare Advantage, I think there's another rail or option too, which is you can elect a high deductible Medigap plan or supplement plan, which is $60 a month, but you're on the hook for $2,900 if something goes wrong. So if you're healthy, you're only paying additional $720 a month in premiums on original Medicare. If something bad happens to you, you're out $2,900, but that's a lot better than $6,000 to $11,000 on an Advantage plan if you get in trouble there. So I think that's an option that when people are complaining, I can't afford the premiums, there's a big difference between $250 a month and $60 a month. Again, it's a risk assessment thing.
That's a great observation. And for those of you who don't know, Charlie is one of our SHIBA volunteers in Tacoma Pierce County. What do you have for us, Chris?
Thank you. If I'm on original Medicare, why am I getting requests on some of my medications for prior approval?
So that would be about the prescription drug plan that you have.
Okay. Yeah,
yep.
Thank you. Yeah,
you're welcome.
I understand. Bye-bye.
Yep. Hey, Aruna.
Yes, I wanted to reinforce what the previous person said about the low, high deductible, low premiums, for the Medigap plan really work, because that is really important. Because if your health needs change, then you are able to change from one, Medicare, like to the high deductible to the regular deductible plan, if your health needs change the following year. But from changing from Medicare Advantage to Medigap plan is not that easy unless your plan is not available in your county, or if you move out of the county and in the new location it is not available. So that is another thing that people need to keep in mind, that you may be saving in a short run on Medicare Advantage, but if your health need changes, then changing to Medigap would be difficult. The guarantee issue part.
You need help to load?
So I'm just watching the clock here a little bit, Derek. I think what I want to do is talk about open enrollment for a minute, and I'm just going to use this same slide to say it is the Medicare open enrollment period. Again, if you have a group plan, they set their own rules about when their open enrollment period is. It may not be the same as the Medicare open enrollment period. So again, if you're like an HCA PEBB person, for instance, or you get your benefits from the federal government or a private employer, Boeing, Weyerhaeuser, pay attention to the mail you're getting from them, because they make the rules about their open enrollment for their group. If you're not part of a group, then October 15 to December 7, so we're about halfway through. And then the main message that we have for people is pay attention. Something you care about almost for sure is changing next year. So don't throw away your mail. Don't ignore your mail. Check your paper mail. Check your email. If you signed up for electronic records or patient portal, if you didn't get a notice from your company about what's changing for next year, please take the initiative and call them. Open enrollment is when you can change your Medicare Part D plan from one to another. You can change your Medicare Advantage plan from one to another. Or as Aruna said, you can switch from having a Medicare Advantage plan to a Medicare supplement, or a Medicare supplement to a Medicare Advantage plan. We have a lot of great resources. This is our website. It's insurance.wa.gov, and we have a specific page about Medicare open enrollment. But as Aruna and Charlie said, we have a list of all the plans that are approved to sell Medicare supplement plans with the premiums, including what Charlie called the high deductible plan option. We have a terrific booklet that explains about Medicare supplement or Medigap plans. You can order it directly from our website. You can download it from our website. We also have information about how to use the Medicare.gov website. So we can have a short video about creating an account. We have a short video about using the Plan Finder tool. And we have a series of videos and content about how Medicare Advantage plans work, how Medicare Part D plans work, how you can switch from one to another, how you can compare them. I put a note in the chat. This year we have created this thing that we call a Medicare Open Enrollment Toolkit. And you can download that from our website or call us or send us a form and we'll ship one to you. If you live close to Aruna, you can go get one from her. If you live close to Charlie, you can go get one from him. They're also available at all the libraries and senior centers around the state. So stop by and get one from them. So be aware that something is changing and make sure that you know what it is. And if you need an appointment, this will help you get ready for an appointment, whether that's with us or, as Matt said, with a broker, or if you're going to just call 1-800-Medicare, this will help you have a better conversation with them or lead you into using the tools at our website or the Medicare website. So 1-800-Medicare, as I said, not affected by the partial government shutdown. They provide service 24 hours a day, 7 days a week. The Plan Finder tool is, I think, a very good tool for navigating your choices. Again, this is for people who have commercial market plan. If you have an employer group plan or if you have Medicaid, you got to reach out to those guys. And here is, again, just a shortcut to the information that we have at the OIC website. This is information about Wiser. The first is the commissioner, my boss, the commissioner's public statement about Wiser. The second is the CMS official website about Wiser. And the third is the list of procedures that starting in 2026, as Matt said, will be subject to prior authorization. About Wiser, I have kind of a wait and see attitude. You know, we don't know how big a deal it's going to be until January comes around, but I want to assure you that we're taking it very seriously and that we are ready to help people who have problems with delays or denials. We would be happy to take complaints, and we do take fraud very seriously. Fraud in the Medicare program is real, and again, we are the Senior Medicare Patrol program, so we would like referrals to prevent, detect, and report fraud. And super happy to have Aruna and Charlie here. You might consider being a SHIBA volunteer. It's very rewarding. You live longer, you live healthier, you're happier. You get the New York Times crossword puzzle done faster. So there's all kinds of benefits to being a SHIBA volunteer, right, Aruna? I want to say thanks to Matt, my friend here at RPEC and the Healthcare Workgroup, and our RPEC in general, Derek and Jacob, thanks. And how about questions before I step off, and apologize that I can't stay all day because I love to talk about it with you.
Yeah, Tim, thank you. Thank you so much. Your knowledge is so valuable, and you say it clearly. You truly understand it at a granular level. And I know, thank you. And I know you have to leave, but we have 2 honest to God SHIBA volunteers who can answer questions. We'll leave it open. And with that, Tim, you can head off and to your next thing.
All right. Thank you all. It's great
Thanks so much.
See you, and thank you for your hospitality. I really appreciate it very much.
Absolutely.
Thanks for your time, Tim.
Thank you.
Thank you, Tim.
Look forward to seeing you again soon.
Yay.
Likewise.
Okay. Bye.
Bye. And I'd like to say, really, to sum up what's going on here, and then we'll take some individual questions. You do not want January to roll around. You do not want Whoa, can you mute that person? Thanks.
Yeah.
You
Got
do
it.
not want January to roll around and your doctor isn't covered. You do not want January to roll around and your expensive drugs costing a lot more. You do not want January to roll around and your pharmacy not covered. You don't want that. So at an absolute minimum, if you're going to stay with your plan, The easiest thing to do is go, oh, well, I'm just going to stay with my same plan. I like it. Well, what happens is your plan changes. And if you don't take the time to reassure yourself that everything is going to be covered like you want it to be covered, then you're out of luck for 12 months. You're going to not have that doctor. You're going to have to pay more for that more expensive drug. And that is not good. So that's the absolute minimum that you need to do. So with that, does anybody have questions they'd like to ask our two excellent SHIBA volunteers? Questions? Oh, that's in chat. Okay. Let me open up chat.
We had one earlier at the beginning in chat from Liz asking about information regarding the medical transportation coverage with Medigap.
No, I don't think Medigap has transportation coverage.
Right. I don't think so.
Medicaid, medical coverage with Medigap. Sometimes during today's no, as far as I know, Medigap plans don't have the coverage for transportation. But if you are on, you can get special mobility services, and you can pay for the medical appointments. If you have accessibility issues, but you don't have the coverage through Medicare, at least through Medigap plans, as far as I know. How about Jim, the other volunteer? Is he there still? Okay. And as far as Liz's question in the chat about changing from Medicare Advantage plan to Medigap plan, transfer of prescriptions, etc. As you choose the plan, Medigap move from Medicare Advantage to Medigap plan, you will be choosing a new physician, and as you do the transfer from your doctor, current Kaiser doctor or whichever MA plan doctor you're seeing, to the doctor in the new doctor that you're going to be have an appointment with, at that time, your records will be transferred and your prescription will go with it too. And once you have those prescriptions transferred, and when you see them for initial appointment, you ask for renewal of prescriptions at that point. And you have chosen the Part D, the pharmacy, when you do the Part D enrollment, and that way, the doctors know which pharmacies to send your prescriptions to. Does it answer your question, Liz?
Well, tell you what, let's move on. And
yes, she feels it is answered. Yeah.
Oh,
okay.
good. Okay, great. Thank you, Aruna. Great answer. And Chris, and then Elliot.
Chris, you're still muted. There you go.
I'm sorry, I forgot my question.
Oh, we'll get back
Thank
to
you.
No,
Yeah. Elliot.
Yeah, Aruna, this is for you. Do you remember that a session or two ago, there was a bill to cover transportation, for in a medical crisis?
That's an ambulance transport, I think you're talking about.
Yes, did that pass?
Right. That did pass. That
okay,
was
so that
legislative session.
People. Who would, let's say I wanted to know about that. Who would I contact? If we need an ambulance and, everything calms down and, who would of course I'll have to pay, but to get a reimbursement, who would I contact?
You may want to look at the Medigap plan or whichever health insurance you have. You can check with them about the ambulance, because Medicare does cover, ambulance coverage. It was the discrepancy, if I remember right, the bill was different ground transportation charges were different, and they were trying to kind of have some kind of uniformity in the transportation charges. So, sometimes it is not too high and some areas it is not too low or something of that sort, if I remember right, the bill. But I can look up the bill number and get back to you on that.
Great. I'd like to present something for the SHIBA volunteers. There are probably some of you are going, gee, I've heard Medicare Advantage, I can get zero deductible plans. And what I'll do is I'll stay in a Medicare Advantage plan until I have, maybe 10 years from now, I'm going to have a serious medical issue. And then I'm going to switch back to original Medicare. I know that when I was starting out learning this stuff, I was going, gee, that sounds like a great plan. I'll just do that. So Aruna, would you like to weigh in on that scenario about whether that's a good way to think or not?
Again, I would reiterate what you mentioned earlier about how much you believe in risk taking, because you are kind of saving when you are starting in a Medicare Advantage plan. You are not paying big premiums, say for 5 years or so. But if your health requires you to have more flexibility in the physicians in the hospital and treatment centers you can access because of the diagnosis of cancer or something, which is not available in Medicare Advantage plan. And when you go out of network plans, the cost increases with Medicare Advantage plans.
And then what about health screening if you wanted to change?
Right. And that is what if people want to change it back to Medigap plan, get on original Medicare and have Medigap so you have a better coverage, then you have to fill out the health screening. And in last 3 months, whatever health issues you had, you have to kind of make a note of that. And based on that, the Medicare gap offering insurance companies can choose the premium, which may be higher than normal because of the high risk, or they may totally deny to offer you Medigap plan altogether. But if you get enrolled in Medigap plan right in the beginning or in first 6 months of your journey as a Medicare beneficiary, then you can get the Medigap policy at the standard rate that you see in the handouts that are available.
And if you had cancer or another kind of serious illness on that Medicare screen, the medical screen question, they could very, very, very well deny you.
Right.
So you're stuck in Medicare Advantage and paying $6,000 to $9,000 a year for your care. So again, Medicare Advantage is not necessarily better than Medicare tradition, Medigap or vice versa. It's just that there are ramifications for both that you need to balance as to what feels good to you.
Yeah, you're taking chances, and hoping for the best. And, then it may work for you. It is, we buy car insurance and we never, hit anybody, but at least we take car insurance, for safety and well-being. And same thing goes with the health insurance, especially as we are getting older and more health issues emerge.
Right.
It is dependent on how much of a risk taker you are, or how much safety and security is important to you when you are not feeling well.
And how much money you have, because let's be frank, if you don't have the money to pay the $250 a month original Medicare Medigap premium, then by all means, you need health insurance and you need to get a Medicare Advantage plan with $0 deductible so that you have medical coverage. We aren't criticizing that. We totally understand
No,
that.
that is
But
true, but there are high deductible Medigap plans available, which are just $60 a month. And
right,
you can, when your health is stable, you can remain on high deductible plan, which is at in 2025 at $2,870, $2,870 maximum. That is a deductible. But once your health decompensates, you can switch it to the regular Medigap plan, and
right.
then it'll be worth your while instead of paying big amounts and having to deal with denials and appeals and all that stuff. Instead of that, have a security. So high deductible plan is a good alternative if you can afford that. And those
Great.
plans are at around $60, at least in Spokane County. Yeah.
Great.
And one other thing about Medigap plans, irrespective of the premiums or irrespective of the insurance company, the plan they offer, the services are same. So you want to look for.
Big point, guys. Big point. Listen up.
Yeah, please keep it in mind, because there is a variation in the rate of premiums of different companies. But choose the one which is the lowest, because irrespective of any company, you will get the same services. That is, whatever Medicare covers, they will pay for it, and they will pay for the co-pays, and also, depending on whether you have F or G plan, they will cover the deductible and such.
For those of you who have Medigap plans, it would really be worth your while to go to the SHIBA website and take a look at the SHIBA Medigap chart of costs. There are some right now that cost $208 a month for your Medigap plan. And for exactly the same coverage, there are some that are $450 a month. And your broker, God bless your broker. There are great brokers out there. But if your broker sold you a plan that's $300 a month for your Medigap plan, and there's one with exactly the same service that you can get yourself for $208 a month, you decide yourself whether you want to pay that extra $1,200 a year to work with your broker. Maybe you do. Maybe your broker, it's so helpful to get a reminder call from your broker every year going, and he or she would ask, hey, what drugs are you taking this year? Let's make sure that your Part D plan is right. But other people, they'll go to Medicare.gov and figure out the Part D plan themselves, the plan finder, and they'll pay that $208 and they'll save a ton of money. So go to the SHIBA website and see what plans are available for you for Medigap. And remember, paying more does not mean you're going to get more insurance coverage. So we have questions. We have Chris, and then Don, and then Bill.
Yeah. Okay. So hi, thanks again. I've noticed when I'm in the emergency room, some teams, when a patient's discharged, will call a cab for them. And I think most of those are on Medicaid or Apple Health. And what I found with my husband's surgeries is if they require that you not take a cab, that you have to have someone pick you up. And for instance, I don't drive. They have a list of contractors who the patient can contract for transportation after a surgery. Or this is another one, clinic discharge, such as rehab at St. Luke's. If the family doesn't drive, they'll say it's up to the family to get a plan to bring that patient home. So that's an extra cost that you have to look forward to. Thank you.
Yeah, thanks, Chris. Don, you're up.
Wow. So these regular Medicare plans that are got the high deductibles, are those like G's or F's or plans?
So Aruna, the high deductible plans, are there high deductible Gs and high deductible Fs? You're muted.
If you were eligible for F, plans are no longer available now, but if you are already on F, when you were Medicare eligible before January of 2020, then there are Plan G high deductible plans available. Yes.
Oh,
Great.
It is 4 to 5. I can see in Spokane County we have it. Yeah.
Great. Thank you. And Bill. Hi, Bill.
Hi there, everybody. Thank you, Matt, for coming to our chapter. And I want to notify people that this chapter has not one person in PEB. So everybody in there is on the open, and the employer offers nothing for over 65. So everybody in our chapter, which is a large chapter, is
King
not
County.
covered by PEB. Therefore, I thank you for that advice. It also answers my question in chat. There is a plan that you can go to for the state that it allows you, even if you're not a PEB member. Is that correct?
I'm sorry, I don't understand the question.
If you're not in PEB,
Right.
can you go to SHIBA and find a plan under that program, a state
yeah.
plan?
Oh,
And that's what you were referring to earlier?
Commercial plans or market plans. The SHIBA volunteers can help with the marketplace plans that are available to people who are not part of PEB.
Okay,
And,
very good.
Yeah. Mm-hmm.
And SHIBA has lists of all the Medicare Advantage plans in your state, in your county, broken out by county. And they have a list of all the Medigap plans that are available in the state. And it's really helpful to look at those charts from SHIBA. They're a little hard to find, but they're there and they're super helpful.
Very good. And lastly, I'd like to tell members that if you or any of your dependents believe that your health is okay, you're probably all right with Medicare Advantage. However, as you get very old, like myself, and you find out what's really going on out there, I would caution you very much at this point to consider a Medigap plan if you can get into it.
Right.
Just from my personal experience, and because Medicare Advantage is not capable of or doesn't have built into it any of the safeguards that we would hope to have in the regular plans. So that's my advice. If you feel you're going to be healthy for the rest of your life, that's fine. But if you don't think that, then I'm saying that you're going into a territory that I went into, which is a gamble. And in that gamble, I lost. So it's just a word of caution.
Thank you, Bill, for your words of wisdom, because when people are starting out, they are only thinking about saving the money, for retirement and etc. But we need to balance, our health needs, because if our health is not good, we can't enjoy the rest, So the other thing I would like to bring it to your attention is before the open enrollment starts in October, you get the annual change of notice, ANOC. And that is the one that you want to pay close attention to, because if you were on a plan, you want to make sure that your doctor is in the provider network. Quite often the provider networks are changed, or your premium, your drugs that you are taking are the tiers of the drugs are changed, etc. So please pay very close attention to your annual change of notice to make sure that if you are seeing a specialist, or if you are seeing your primary care physician, they all are still in the network, and also to your changing health needs will be met by this program, Medicare Advantage plan. One other thing I can say is there are, as I mentioned before, if your Medicare Advantage plan is not offered in your county, then you can change to Medigap plan, and you don't have to fill out the health screening form. So if you get a letter from your Medicare Advantage plan that it is not available in your county, then that assures you transitioning into Medigap plan. Please keep that in mind. Or if you move to a new location and in that county that Medicare Advantage plan that you are on is not available, that also gives you a chance to switch to Medigap plan. Please keep that in mind.
Please keep that in mind. And what Tim would say is, please read the letters that are sent to you by your insurance company, particularly at this time of year. Please read them. Please, please, please. They have to, by law, tell you what's changing. They have to, and you have to read it to find out what's changing. Okay. Betty Ray and then Dawn.
Okay. I'm just kind of responding to Bill's comment, and I took the gamble on having good insurance, and unfortunately it did really pay off last year because I spent like 28 days total in the hospital last year.
Ooh.
So having the good insurance paid off. So that's a gamble that you take. But it paid off for me. So just telling you that it can happen.
Yep, it can.
I'm glad you are feeling better, Betty Ray, but thank you for your kind advice.
Yeah, Dawn, did you have a question?
I think it got answered.
Okay.
If you're on an Advantage plan and you want to try to go back to strictly Medicare, there's precondition requirements that may come into play.
Yeah, a health screening. They're going to ask you questions about in the last 3 months. Are there any big things going on medically? And if you put down things like, again, I'm not a trained volunteer, but if you put down, I have serious cancer, or I have just come down with some chronic disease like, let's say ALS, Lou Gehrig's disease or something like that's going to cost that Medicare Advantage plan a lot of money. I mean, the Medigap plan a lot of money. They have the right to say no, and they do that sometimes.
Oh.
But what Tim Smolen suggests is apply to 4 or 5 different Medigap plans. Just don't apply to one. Apply to multiple ones, because there's some that might take you and some that might not. So, be smart about it and widen the field as much as possible to see if somebody will take you, even if you're pretty seriously ill. Yeah. Thanks, Don. Anybody else? Or are we wrapping up here?
I want to say one more thing very quickly, and that is, if people are separating from the public service or from the teaching before the age of retirement, they can defer accessing their PEBB benefits or PEBB or SEB benefits when they are eligible for Medicare. And, it does lead to saving, but you have to make sure when you separate from the public service or from education, from the school, teachers sort of jobs, that you defer it. So work with your HR so you don't lose that benefit, because the PEB premiums, because of the subsidy, are lower than what you will pay in the commercial market. So remaining in PEB is more beneficial if you plan, accordingly. Please keep that in mind.
Excellent. With that, I think we're at the close. I hope this has been helpful, because the health insurance system in the United States and for retirees is just too darn complicated. It's really complicated. So we hope to have given you a little bit of insight here. Yes, Aruna.
Yeah, there is one question in the chat about do we
Okay.
know yet if VISAR will require pre-auth for procedures currently authorized? It depends on, there are 17 procedures that have been identified, at least for 2026. And if one of yours, you may want to check with your physician if one of yours is under that category. And
Good
then you can
answer.
find more information because they are requiring certain amount of documentation for each of those 17 procedures specifically.
Thank you, Aruna. Aruna is so knowledgeable on this, isn't she, guys? So thank you. What a resource for us. And go to the SHIBA website. Go to the RPEC healthcare webpage. Call up SHIBA. Good luck, though. They're super busy right now. Don't wait if you need their help. Go to the library or senior center and get that open enrollment packet from SHIBA. It's incredibly helpful. So you have resources.
Looks like this.
It's super. Jumpstart Toolkit. Super.
Am I holding it right or do I need to hold it the other way? I don't know.
No, you got it right. It's incredible. Unbelievable.
This is the folder. Please get that Jumpstart Toolkit from the library. I thought if you see it, then you will have an idea. So
every time I look through it, I learn something. So with that, thank you. Appreciate it. Thanks to Derek and thanks to Jacob for running the show. And with that, we'll see you later. Thank you so much.
Thanks, Matt and Aruna. And thank you, everybody.
Bye-bye.
Bye.
Bye.